السلام عليكم دكتور محمد.
وعليكم السلام، اهلا مرحبا. دكتور طارق.
معك دكتور طارق. نعم
دكتور طارق، كيف الحال؟
حياك الله دكتور محمد، معكم من جديد مع الميوم مرة أخرى. نشكر الدكتور محمد العمري، أيضا نشكر الدكتور خالد عياش، الدكتور بيريا، والدكتور صفان البياتي، والدكتور صفا جهاد، والدكتور جورج روتش. الميكروفون معك دكتور محمد، أهلا وسهلا بكم إن شاء الله.
Thank you very much. السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. First of all, I would like to thank Yemeni Ophthalmic Society for giving us this opportunity to meet our colleagues and friends in Yemen. And again, from yesterday we meet, and on the Retina session today we will have anterior segment. It will be about cataract, and today we are having an really eminent speakers from different parts of the world. I would like to introduce all of them. Can you, Soria, please share with me the screen? Dr. Ashraf Armia. Dr. Ashraf Armia is a consultant cataract and cornea and refractive and anterior segment reconstruction surgeon. Can you enlarge it a little bit? You know, now we are older age, so above 40 we need a little bit to be presbyopic correction. Founder and medical director of Ashraf Armia Eye Clinic, Cairo, Egypt. Also, we have Dr. Khalid Ayyash, consultant ophthalmologist and anterior segment surgeon, director of Al Hikma Eye Clinic, eye specialty hospital, Amman, Jordan. We'd like also to welcome Dr. Priya Narang from India. This is the second time she participates with us. Thank you, Dr. Priya, for being with us. She is an MS director, Narangia Eye Care and Laser Center, Ahmedabad, India surgeon, clinical research, medical educator, innovator. We are having my dearest friend, Dr. Safwan Al-Bayati, is a well-known cataract and refractive surgeon, consultant ophthalmologist, and he is the medical director of New Vision Eye Center, phaco and refractive surgeon, cataract LASIK, vitreoretinal surgeon in New Vision Center in Dubai. We are also proud to have today with us also Dr. Militos Validis. He is an PhD, people ophthalmology, ICO of. He's a surgeon of the cornea and anterior segment. He's a president of Helen Clinic, I think, Society and of Intraocular Implant and Refractive Surgeon, director of Ophthalmic Eye Institute, president of Southeastern Society of Cataract and Refractive Surgery. Maybe he will join us, or otherwise we are having his presentation in record. Also, my dearest friend, Dr. Safa Jihad from Morocco is welcome. Dr. Safa, thank you for being with us also. She is a cabinet, and Dr. Safa, she is a consultant ophthalmologist and cataract and refractive surgeon from Morocco. So the first presentation, it will be by Dr. Khalid Ayyash, and he will talk about what new in biometry. Dr. Khalid, the mic with you.
Thank you, Dr. Muhammad. I'm very happy to be in front of a lot of colleagues, a lot of seniors, a lot of colleagues that we practice together here in Jordan. A lot of Yemeni doctors were coming and joined our services here. I'm very glad to be with them again. Thank you for the invitation. I will start sharing my screen. I will be talking about what's new in biometry, and my main speech will be about the new formulas. Is the screen clear? Can you see my screen? Okay.
Yes. Now
what's new in biometry? Nothing to disclose financially. I will start by updating on the formulas. In 2010, we only have very few formulas. In 2015, we start have more and more formulas, and nowadays we have plenty of formulas, and most of them are doing well. Most of them help us as an anterior segment and phaco surgeon in improving our outcome, and help us and help our patients to get a more accurate and desirable results. So the older classification of formulas into first and second generations, maybe this is not true nowadays. So the classification now is based on other criteria like the historic, the refraction-based formulas that are not used nowadays. Also the regression analysis formula like the SRK and SRK2 formulas are also not used nowadays. Now we have the divergence formula, which are based on geometric optics, and now these can be classified depending on the variables that they use, like two variables, like the Holiday one is RKT, Hoover Q, they use the axial length and the keratometer. We have the three variables formulas that use, in addition, the anterior chamber depth, like the Higgs and the Ladas formula. And then we have the five variables like the Barrett universal, two formulas. And also we have the 7 variable formulas like the Holiday 2 that use, in addition, the refractive and the age of the patients. And nowadays we are hearing a lot about the artificial intelligence-based formulas like the HEL-RPF, the Clerk neural network, and the CAN formulas, and also the ray tracing formulas like the Snellen's law that uses the Snellen's law of refraction, like the Olsen formula. And we have mixed formulas that use like the ray tracing and artificial intelligence and so on. So what is the ideal formula that most surgeons nowadays are looking for? These formulas, the ideal formula should have more than 95% of eyes within less than half a diopter of the predicted outcome. One formula that fits all the axial length, whether short eye, long eye. This formula, the ideal formula, should be used in all these axial lengths, and also this formula that should fit the unusual eye conditions like keratoconus, post-refractive, post-RK patients. Also, it does not require any additional corrective formulas, and it does not require surgeon factor optimizations. And also, this formula should be suitable for toric IOL and should take into account the posterior corneal astigmatism. And preferably, this formula should be available on the machine that make the results rather than taking our measurements into online and do the calculation. So this is the ideal formula that we are all looking for. But is this the situation nowadays? Let's see. In 2008, the source of refractive errors in biometry, according to Norby, was the estimated lens position was 35% of the error was due to estimated lens position. 27, almost 1/3 was due to axial length measurements, and 17 due to refractive errors. But nowadays, the source of error, axial length, is off the list because we have excellent optical biometry machines that gives very accurate measurements in the axial length. So we excluded around 1/3 of the error. But it comes that the cornea is another source of error because nowadays, with the better understanding of the anterior curvature and the posterior curvature, the cornea is another source of error. This is the updated biometry machines like the IOL Master 500 and now is the 700 or the Lens Star. El Pentacam, they have the AXL Oculus from Nidic. We have also machines. And if you don't have the optical biometry machines, and if you try to using the A-scan, then the emergent technique might be more accurate as it encounter less errors in the axial length measurements. Most definitely, if you have access to the optical biometry, this is the standard nowadays. One of the most known formulas nowadays is the Barrett universal 2 formulas. It's based on ray tracing. It differs from the conventional formulas in that it takes into account the changes in the principal planes that occur with different intraocular lens powers. And it uses 5 biometric parameters to predict the effective lens position and IOL power, the axial length, the keratometry, anterior chamber depth, and also it takes into account the lens thickness and white-to-white measurements. And it continues to evolve via data-driven enhancements. Barrett, it's not just a single formula, but it's a suite of formulas. And this changes the calculation depending on whether the optical configuration alters from biconvex or meniscus lens. and it does not require any additional correction factors such as axial length transformation or unusual constant for patients with high or very short axial length. The Barrett suite includes the Barrett Universal 2 formula, is the core of this formula. Then we have the Barrett True K formulas for patients with prior myopic or hyperopic laser vision correction or keratoconus patients or even RK patients. And we have the Barrett toric calculator for toric IOLs, and we have the Barrett True K toric calculator for toric lenses for those who underwent laser vision corrections. And there is a very important formula of these is the Barrett treatment formulas. It's make an analysis of the outcome, and if we have to change the IOL or if we have any errors in the outcome or unusual outcomes, then we can get to this formula and it gives us the best solution. As we said, the Barrett True K formula is derived from the Barrett Universal 2 formula and it incorporates a modified double K method and can be applied to eyes that have undergone laser vision correction, as we mentioned. This is the online platform that we can see. If we can get access to this formula online, this is what we can see here. We can have the data of the patients. We enter all the mentioned data, and then it makes the calculation and it gives us the predicted outcome. This is for the toric IOL calculation also. The Barrett True formula and the Barrett toric calculator. It gives us the axis, the power of the lens that is suitable once we enter all the required data. The second formula is the HEL RBF formula. RBF stands for radial basis activation function. It's based on artificial intelligence regression model using pattern recognition and sophisticated data interpolation. It's optimized with the Hagstreit LensStar LS900 optical biometry. This is ideally, if you have the LensStar 900 machine, then you can use this formula as it's part of its software. And it's ideal also with the Alcon SN60WF biconvex intraocular lens and the Alcon MA60 meniscus design intraocular lens. It's entirely data-driven and free of calculation bias. It gives a validating boundary model indicating when it's performing within a defined area of accuracy, as we will see. HEL RBF, initially it was based on 3,400 patients. The range was from 19 to 30 millimeter of axial length, and the biometry range was the keratometry range was from 37 to 49 diopters, and only at the first they use it for biconvex IOL only from +6 to +30. Then the second version, they expand the patients to more than 12,000 patients with addition of more than 1,000 cases of very short axial length. And also in version 2, they have the meniscus IOL design from -5 to +5 diopter lenses. And this is the platform for this lens, and this is what I meant by inbounds or outbounds. This is artificial intelligence formula. If anything went wrong or any of the data is missing or any of the data that you are giving to the machine is out of the values that the machine have, it will give you that this is an out of bounds. Once you saw that it's out of bound, it's preferable not to use this calculation and not to consider it. If it gives you its inbounds, then the measurements will be accurate and you can use it. This is the good thing about this formula. And here also we can see the platform online for the HEL RBF. It can be used with other devices like the IOL Master. Then you need to enter it that you are making the calculation using the IOL Master device. But as I said, this is artificial intelligence, and the way that artificial intelligence works, there are millions of information that the system uses that we as humans can't understand or can't explain why this result. So if you use other machines, you can enter, and then it will give you if this within inbound or outbound. As we can see here also, if you use, for example, CT Lucia lens, for example, it gives you that this is out of bound because there is not enough data about this lens in this system. But when it gives you, there is no mark here, then you can use the results. The third formula I will be talking about is the Ken formula. It's based on theoretical optics and also incorporates regression and artificial intelligence. The Ken formula uses the axial length, keratometry, anterior chamber depth, lens thickness, and central corneal thickness and gender of the patient to make its prediction. And this is the platform which is available online for this formula. Other formula is the Olsen formula. It uses ray tracing methodology. It comes into two-factor version that uses anterior chamber depth and lens thickness to predict the post-operative effective lens position, and a four-factor version that uses additional parameters of axial length and corneal curvature. So the two-factor version does not use the corneal curvature, and this might be suitable for patients who underwent laser vision correction. The Olsen formula, it uses the C constant factor, which defines the IOL position in terms of the crystalline lens anatomy. It's not dependent on the K readings nor on the axial length. They found that the position of the eye, what's the C constant means, that they found that the position of the IOL after standardized capsulorrhexis and in the bag implantation is closely related to the preoperative anterior chamber depth and lens thickness. And this knowledge stems from accurate measurements of the exact position of the IOL following surgery, as can be done by laser biometry and other technique. The EVO formula also one of the newest formula. It's based on the theory of emmetropisation and generates an emmetropia factor for each eye. It's a thick lens formula and takes into account the optical dimensions of the eye and can handle different IOL geometry and power. It uses the axial length, keratometry, anterior chamber depth. And also other variables can be entered and can add in the accuracy is the lens thickness and white to white. There is also a version 2 to improve the prediction for long and short eyes and toric eye OL, and also can be used post myopic laser vision correction. This is the platform for this formula. LADAS formula, it's not a new formula. It's rather than working by optimizing multiple formulas and choosing what is the best formula for each of them to make a super formula. This formula will choose the most ideal one to use, further optimizing the values over time using both individual and the crowdsourced data. For example, for short eyes, it uses the Hofer Q formula. For long eyes, it uses the Holiday with the adjustment factor, and for other eyes, it used Holiday 1 formula. So it's like if you are going to a trip, rather than going into different online sites, then you can go to one site and it makes the calculation. And this is the idea behind the LADAS formula. It takes the data and it takes many formulas and incorporates which is the best formula for you. This is the platform online, which is available online, and it gives us a very good outcomes. ESCARS recently introduced an online calculator. It's still evolving, but it has many formulas that can also do the calculation for you. The last formula I will be talking about is the Purell DGS formula. It stands for post-operative spherical equivalent prediction using artificial intelligence and linear algorithm. DGS comes from the name of the developer of this formula. And it's available online. The nice thing about this formula, if you are doing a second eye, then you can enter the data that you did for the first eye, and this will add in giving more accurate results for you. So these are the formulas. Which formula we are using? These are the websites for each of these formulas, and most of them are free. Some of these formulas you need to have access to go in, but most of them are you can get free access and you can use them online. Which formula to use? I just will go quickly on the literature to see what the literature said about the formulas used. This is a very big study that was done in the United States, and was the aim of the study to answer 4 questions. Number 1, which is the most accurate formula in eyes of all ocular dimensions? What is the accuracy of various formula when evaluating short, medium, and long eyes? And what is the extent of bias within each formula? And the 4th question was, does the use of the Van Gogh axial length adjustment for the Hakes and for the Hofer Q and the Holiday in long eyes lead to improved outcomes. So this is the 4 questions that this study was aimed. So at first they incorporated around.
Khalid, if you allow me, can you conclude, please? Because we are 2 minutes over the time already.
Okay, I will conclude in 1 minute. So this is the study. They included more than 37,000 eyes, and they found that the accuracy of the Barrett, Olsen, and the Higgs formula. And I will go through all these slides quickly. And in conclusion, they found that the Barrett and the Olsen formula has the best outcome in terms of accuracy and post-operative spherical equivalence. And between axial length of 23 and 25, all the 7 formulas are given very good results. And the one one of the outcome that was in contrast to the expectations, that they found that the Hoover Q had the worst performance in short eyes for both type of IOLs. This is in comparison with the newest formula, like the Kane and the Barrett formula. But if we want to compare Hoover Q in short eyes with the older formula, no, Hoover Q do better than this formula. So in conclusion, best practice nowadays is to obtain measurements with modern accurate devices, optical or swept source OCT, obtain accurate keratometry, better to take total keratometry. The best machines to be used in this situation is the multi-zone LED devices. Use the best formulas, validate your results, and always explain to your patients about the outcome. And thank you very much.
Thank you very much. Okay, sorry, Dr. Ashraf, go ahead.
Thank you, Khalid. Very nice. It's very nice overview of all the formulas in the market now with the updated forms also. Before we go to Dr. Perea from India, I just want to highlight first, I want to thank the Yemen Ophthalmology Society, because this is my first time between the Yemen Society and the ophthalmologist. So I'm happy to be here. I'm just going to highlight in 2 minutes a conclusion of what Dr. Khalid said. In extreme eyes, we should do more than 1 formulas. Effective lens position of the lens is very important in the final calculation and the final results. Abnormal corneas, you should do more than 1 calculation. Don't depend on 1 calculation to get the best. And if you find that there is a difference, so you can choose between what is the best. Toric calculation, as mentioned by Dr. Khalid, it's very important using the calculator, either the Barrett calculator or the formulas, toric formulas from different companies. Depends on the IOL you are using for toric IOL. And finally, yes, the short eyes, especially in the short anterior chamber, it's not an easy way to calculate the IOL, especially for the effective lens position for these cases. And finally, if you have a subluxated lens or pseudo-exfoliation, always expect in the calculation of the effective lens position, it will be different post-operatively or after 1 to 2 months, because there are changes in the zonular contraction of the lens.
Dr. Mohammed, 1 comment for the short eye. Dr. Khalid, excellent presentation. And it was summarized for all the formula. Only 1 comment for the short eye, as Ashraf said. And when the AC depth is less than 3, I will go to the Hoover Q. And I compare between Hoover Q and Barrett and Hills. As you know, that Hills is not a formula, it's only collecting data. And they are improving their performance. There is no any formula in Hills. Anyway, I found that Hoover Q, it can be varied between Barrett Universal 2 and Hills and Hoover Q. There is a plus minus 0.25. And this plus minus 0.25, when you are using the premium lenses, definitely it will differ, especially when you need to target a minus 0.25, and then you will use in those very short AC, a Barrett or Hills, it will gives you either Emitrop or plus 0.25. So these are the difference, because when you are putting, for example, 2.3 AC depth for fourth generation, the difference will be 0.25. Why Hoover Q here, it's playing better because Hoover Q, they are not considering because Hoover Q is a third generation, so it's not considering the AC as a part of their calculation. So the effective lens position will be on a calculation of the corneal power and the axial length. From this point of view, Hoover Q can be better in the short AC. When the AC is less than, for example, for me, I'm considering it when the AC is less than 3 millimeter. Great, thanks.
Thank you, Dr. Safwan. If there is any question from your side, Dr. Tariq.
حد يسأل يا شباب. Next speaker, there is no question.
Okay. So I will love to introduce Dr. Priya Narang from India. She is a very eminent surgeon and eminent ophthalmologist worldwide. And the topic she is going to talk about, it is innovated by her and Dr. Amara Gorel, the whole team. It's a very important technique in cases of abnormality in the corneas. She's going to highlight this, I think, in the most proper way. So she's going to talk about pinhole pupilloplasty in cataract surgery and optical concept. Please, Priya.
Thank you so much. And it's such a wonderful honor to be here. Thank you so much, Ashraf. Thank you so much, Dr. Mohammed Al Amri, for involving me. And it's again a pleasure to see you everyone back. So I will just share my screen and yeah. So I hope it is seen there.
Yeah.
Yes.
Yeah.
Yes.
Thank you. So I begin my talk here, pinhole pupilloplasty in cataract surgery and optical concept. So actually, the question props up that why do we actually need to do this when you're doing a cataract surgery? There's a very simple answer to this, that it's always wherever there is a higher order aberration, it is only there that we consider doing a pinhole pupilloplasty procedure. Because we all know that the pinhole optics, they try to impart the best visual acuity to the patient whenever there is a defect. Now, coming up to this is just an animation that, it just describes how this procedure, it actually works. This is a case of RK, and the patient has immense higher order aberrations. And we know that the aberrations, they are directly related to the size of the pupil, and the patient never sees anything clearly. So in these select group of patients, what we try to do here is that we try to impart pinhole optics by narrowing down the size of the pupil. And that is how we go ahead with doing a pinhole pupilloplasty. The other concept here would be to impart a pinhole optics would be to use a pinhole intraocular lens if it is available in your part of the world. And if it is not, this can be definitely done for the patient. The prerequisite just being that you need to know how to do a pupilloplasty procedure. So coming up to this fact that whenever we have this procedure, when we need to do this procedure in a pupilloplasty, this is actually a bit of a technical procedure, but whosoever knows it can do this very well. Now, to highlight this fact, this is a case of RK, and the patient has 12 to 16 marks, deep marks on the surface of the cornea, and patient has been operated for cataract surgery, but the patient is not happy just because that everything is proper, but there are higher order aberrations, and these are massive higher order aberrations wherein the patient is just not happy with the kind of visual quality which is there for the patient. So here we are trying to narrow down the size of the pupil, and wherever you take up this the technique, we always choose a single pass pupilloplasty procedure because it's a very easy procedure, a very simple way of closing down the pupil wherever you actually need. The point here is that whenever you're trying to narrow down the size of the pupil, you need to center it around the Purkinje-1 reflex. That's a prerequisite for doing this. And specifically in this case, when you have those deep corneal marks, what you actually need to do is, you need to pass your needle from in between the two RK marks which are present, and you should not disturb the RK marks which are already present. Now, coming up to this case, this is how you see this case in the immediately on the table. Your pupil should be immediately centering this, because we always try to target and have the size of a pupil which is around 1.5 to 2 millimeter in size. And we have seen that whenever you target the size of the pupil around the Purkinje reflex, it comes down to anywhere around 1.5 millimeter. And we have done further studies, and the paper is going to be through soon. The optimum size of pinhole that is needed for patient, it varies from patient to patient. There is no one pinhole size which works for all the patients. So this is just the basic concept that I'm just trying to show here. This is a case of a cataract, you can see, and this is a PK has been done for this patient, and we are trying. Definitely this patient again has a higher order aberration. No matter how well you do the cataract surgery, this patient is not going to be happy in the postoperative period. So these are the cases that we electively choose these patients for doing a pinhole pupiloplasty. Now you can just see in this case again, we will be bringing down the pupil from all the sides. So all that we need to do is that, we just take this. This is a long arm needle, which is attached to the 9-0 polypropylene suture. We pass through one end of the iris tissue, and then we railroad this from the other side. And then we just bring the loop out. We take 4 throws through the loop and we pull this. This is just, I'm just describing the method of single pass that we try to adopt. Why we try to do this is that, we just need a single pass in this, and we don't have to redo it again and again. Because, when you are doing a pinhole pupiloplasty, you need to bring down the pupil from all the sides. So actually you need so many interventions in the eye. You at least need to do it 3 or 4 times to bring it down from all the sides. That's what you're actually seeing there. So now this is a technique which works fast, and it makes things pretty easy. So this is how this actually works in case if you find that the iris tissue is overlapping the Purkinje reflex, then we can use a vitrectomy probe, and then we can cut all around it. So this is just a pre-op and the post-op image of this. Recently, I think I would like to take this opportunity. This is a newer technique which I have introduced. This is the reverse photoretinoplasty procedure. This is the track of the suture, how it goes inside the eye, and how we get the knot. This is exactly the reverse of a single pass photoretinoplasty procedure. This procedure, normal procedures, we all have knot in anterior chamber, but with the reverse throw, you get a knot on the posterior surface of the iris tissue. So I just take this opportunity to just show you this the technique of reverse video. This is a case which I'm trying to show you. I'm trying to bring down the pupil in this case, and we take this needle and we enter from the posterior surface of the iris tissue onto the anterior surface of the iris tissue. And similarly, we do it from the other side also. Now you would say that what's actually the need of doing this when you can do a single pass photoretinoplasty? Why not do this? This technique actually I actually supported for cases that are scheduled for endothelial keratoplasty procedure, because you do not get any suture knot into the anterior chamber, and because that's the area where the graft gets handled, and the endothelial graft remains quite safe. So this is how you see the suture goes in, and the remaining procedure remains the same. It's just the passage of the needle that makes the difference in this technique. The remaining procedure is the same like a single pass 4 throw. I just pull this loop out and just take the 4 throws, but the knot slides and goes back onto the posterior surface of the iris tissue. So this is one of my peer paper, which is soon due in one of the journals. And this is how you see we need to take 4 throws for all those people who are not into doing pupiloplasty. I would just like to mention that when you take 4 throws through the loop, it creates a self-locking mechanism wherein the suture loop does not open. And it leads to apposition of the iris tissue very well, and you do not have to take a second pass again. So this is how you see the suture is being pulled from both the sides. The knot slides onto the posterior surface, and actually it looks so beautiful in the postoperative period that you will not even recognize that you have done a pupiloplasty in this case, because you do not see the knot which is there. So you just feel that it's just the apposition of the iris, and I also call it as an iris stapling because it's like a staple. It goes behind. This is the anterior segment OCT. You actually cannot see anything in the anterior chamber because there are no knots in the anterior chamber. Anyway, coming back to the fact that, these are the cases. This is one of the cases that I would just like to show you. The patient had a refractive surprise. This patient has undergone everything. The patient has LASIK, undergone LASIK. The patient has also undergone cataract, mixed astigmatism. The patient also had pseudo-exfoliation with CTR into the bag and all. So now these are the cases, where you would not just like to touch the capsular bag because you know that already everything is compromised and everything is being done. So the best thing to do is, what I would actually do is that, you just narrow down the pupil and the patient is fine. So this works beautifully. And this is how we, as a team, we described it with Dr. Jack Halliday and with Dr. Agarwal. We described this, the effect of the pinhole pupilloplasty for higher order aberrations. And we assess the visual quality and the depth of focus for the patients in the photopic and the mesopic light conditions for distance, intermediate, and near vision. And the patients, they really responded very well. And this was the defocus curve. We all know that whenever there is a pinhole coming up, you always get that extended depth of focus in these patients. And it is this extended depth of focus, that really helps these patients, and it really makes life very good for them. And these patients, they have a very high satisfaction ratio post-operatively because they have never seen anything so clearly in their life. We also assess the low contrast visual acuity for these patients, and these patients, they really work very well. Thank you so much.
Thank you very much, Dr. Abriya. I think Dr. Ashraf.
Yes, it was a very nice talk as usual, and another innovation coming from the same team, the reversed knot. I think it will be the coming knot because it is better cosmetically inside the eye, and you cannot, and even the iris will be tucked down, not up. So this will be better cosmetic for the patient.
I have two questions, Dr. Ashraf, if you allow me, for Dr. Abriya. First of all, thank you very much. It was an excellent. Congratulations for this innovation. Suppose we are having a patient and he is a diabetic patient and we want to see the posterior segment in this patient. After we do this, what are the things that we are going to face for dilatation and doing the other things?
This is a very valid question because everybody has this thing in mind that how we are going to do it. For examination, I would say that, maybe it might be just difficult through the 1.5 millimeter pupil to see behind, although you can just see the central fundus. But now there are ultra-wide imaging devices, like I have no financial interest, like we are using the Nidec Mirante and all. They actually give you the entire periphery of the eye. You can see up to the periphery, you can take those images and you can see even the periphery. Coming up to the intervention that you are saying, that if we need to intervene these patients, maybe these patients might go in for surgery for the posterior segment, then I think the surgeon, the posterior segment surgeon, they can just cut those sutures and then it's done, and they can perform the entire surgery if at all it is needed in the future. So things are not that difficult as it seems, because the immediate result that we give to the patient is phenomenal.
There is another question, as I mentioned, Ashraf. Can we correct this high order abrasion instead of going to do this one by, doing a laser interventions?
Laser interventions. Well, no, these patients, they're actually not happy patients because laser interventions, I don't think they're going to help too much in these cases, because these cases we choose, very carefully, wherein we have to do a pinhole, imparting the pinhole optics to the patient. I don't think anything else is going to help them. The only thing that you can do is you can use a pinhole IOL if it is available in your part. These are the only two options.
I think that, the patient, especially for RK, what I'm doing is that I'm starting with the laser treatment. I do agree with you that it's not an easy, and it need high selective treatment of the higher order abrasions, because they have a very high spherical abrasion and they have a very flat center. So remodeling of the cornea with the remodeling of the epithelium, because they have a very thick central epithelial layer. to remodel the cornea. So I do agree that it's not an easy, but surprisingly, when you are treating those high order abrasions, especially for those that they have an RK, they will be, their vision is improved in a way that they will not do the cataract, because part of their vision deterioration is the high order abrasion. So I did it, yes, I have few cases, and they are happy. And then then I did the cataract, and they end up with a reasonable vision comparing to the pre-op situation. Definitely I'm using my machine that Schwint and can treat all those high order regions selectively. And we compare the epithelial thickness of the center, because in MS39 we could compare the thickness of the epithelium, and it's remodeled in a beautiful way.
That's great.
Continuing, Dr. Safwan, I'm using the same technique for the unhealthy corneas. It's give better results. But how you can measure with a very small pupil, 1.5? For me, I feel it a little bit difficult to calculate the high order abrasion, the refraction of the patient, because most of the machines, if the pupil is very small, it's very difficult to get a refraction for the patient. And also, if I'm using, say, for example, for me, the eye trace, it's very difficult to have a high order abrasion in 1.5 pupil.
So Ashraf, here you are talking about post-op, or we are talking about pre-op?
No, I'm talking about post-op.
I'm talking about pre-op. First of all, what we are talking about is not a ocular high order abrasion. You are talking about ocular. That's why the pupil size is very important. I'm talking about the corneal wavefront. So I'm talking about corneal high order abrasions, because those patients, it's not an important for them an ocular, because there's no ocular, it's a corneal. So when you are using the eye trace, it will give you definitely the ocular and corneal. Here, what we need is the corneal, and we need machine that connected to that corneal wavefront that can treat those issues selectively. So pre-op, the pupil is within the accepted limit, so we can treat it. And corneal wavefront doesn't depend on the pupil.
Yes. No, I'm not talking about pre, Dr. Safwan.
Oh, okay.
Yes, Priya, you put a pentacam, and the main issue or the main concept for pinhole pupiloplasty is the decreasing the high order abrasion. So how, from your side, how you are calculating the post-operative high order abrasion in your center?
See, actually what happens is that post-operatively, there is not going to be much change in the higher order abrasion, because we are not doing anything for the higher order abrasion. We are only bringing down the size of the pupil, right? Now, when we bring the size, it automatically filters all the abraded rays. So it's just the central rays which are passing through the center of the eye. And that is what get. For the benefit of the patients, what we can actually do with what we do is that, we have that customized pinhole size. We put that in front of the eyes of the patient, and we'll make them see that, okay, are you happy with the 1 millimeter size? Are you happy with 1.5? Or you are happy with 2? Or you are happy with 2.5? And you will be surprised to know that all these patients, they are not everybody is saying, I want 1.5 or there are patients who say, no, I'm fine with 1 millimeter. Some patients says, I'm fine with 2. So it's just like, we just try to show them before the surgery that, okay, look, this is what you are seeing right now, and this is what you are going to get in the post-op. If you're happy with this, we go ahead, otherwise, no.
Thank you.
Yeah, just one thing. If you are going to the map of the high order abrasions of the cornea and measuring 7 millimeter, and then 6 and 5 and 3 and 2 and 1, when you are reaching 1, the value is very low, almost null. So
absolutely, it goes down.
So according to that, the pupil size will go to the almost null, which is the center.
Absolutely.
Thank you, Perea. And we are going to the next talk. I think.
Can we ask Ashraf if there is any question from the panel there? Tariq and anyone from the colleagues have any comment or question for Dr. Priya?
Okay, so we are, I think we can go to Dr. Safwan. For me, I love seeing Dr. Safwan, watching him doing the 4 flange. I enjoyed in last October. So I think everyone attending today. He's going to enjoy what Dr. Safwan is doing, either the Yemeni or the four flange, but it will be different with him. So you are going to enjoy all.
Great, thanks, Dr. Ashraf and Dr. Mohammed. And I was very happy to join this eminent speakers, Priya and Safa and Khalid and Ashraf Armia. And this group is, they are very close to me. They are all, but only one comment that Mohammed started with a presbyopic for all. It's all, that's right, I agree, for all except Priya and Safa. They don't have presbyopia, Mohammed. So please, just correct that. Anyway, well, just yes.
I know, and
Khalid,
I just want to thank you for this precision. I agree. I totally agree. Thank you. Thank you,
Mohammed. And you are interfering with them. So Safa and
I was talking about myself only, Safa. All of you are younger than me.
So returning back to Yemeni technique and four-flanged, I'm very happy to present that to our brothers in Yemen. And if we'll start, let me start with the Yemeni technique and let us say that why we are reaching to Yemeni technique. Surgical techniques for secondary IOL implantation is not a new thing in the absence of the capsular support, have been accomplished by using an anterior chamber IOL, where in the past we had that only, and then iris fixed IOL, and then we had the revolution of transscleral suture posterior chamber IOL. That was a revolution because it supports the lens posteriorly, and we will not affect the endothelial cells, and there is no erosion of the iris. So the transscleral IOL suture technique has advantage over the other technique, which can cause corneal endothelial cell loss, glaucoma, peripheral anterior synechia. However, suture erosion and breakage remain significant concern when using the transscleral IOL suture. Suture breakage was observed in 27.9, almost 28 of cases 6 years later, and especially when you are using 10-0 polyproline suture. Some surgeons have used a Jortex, like me, suture to decrease the risk of the suture breakage. Now, if we will go to Yemeni technique, first, before that, Agarwal introduced a glued IOL. The intrascleral IOL fixation technique was reported by Gabor and Agarwal, a sutureless technique for IOL fixation. This technique can overcome the risk of the suture-related complication, but has a potential risk of postoperative hypotony, scleral, and we need scleral flap, we need peritomy, and the use of biological glue. And there is a myopic shift because of the length of the suture, and that should be away from the limbus in about 1 millimeter, and to get a good enough haptics length. Yemeni and his colleague develop a new surgical procedure that can be carried out via the conjunctiva, in which the haptics of the IOL are fixed strongly to the sclera without using scleral flap, no peritomy, suture, neither suture or glue. They have named this technique flanged IOL fixation because they create a flange at the end of the haptics for firm fixation by using double needle technique. A double needle technique that's took the other name of the procedure as a double needle technique, then it's modified to the name of the founder. That can minimize the sclerotomy to 27 gauge and decrease the risk of postoperative hypotony. Now, during this period, Brian Kim came with a modification, a radical departure from the original Yemeni technique, because the trailer haptics here in this technique is fixed before the leading haptics, thus bypassing many of the technical challenges. The simplest solution is to externalize the leading haptics out of the eye through an inferior limbal at 6 o'clock incision, as what I will show, And this is made even easier by using a one-step injector assisted technique. This maneuvers cure the IOL from slipping too far posteriorly into the eye. And because the IOL side more anteriorly access to the trailing haptics is enhanced for a needle fixation. Now, what we need for the Yemeni technique, we need the special lenses, those lenses having haptics called polyvinyl fluoride. So it's not a PMMA, because we can use PMMA, that's right, but cracking of the PMMA haptics is a big problem here in this technique. In our region, in JCC, we have the sensor from Johnson & Johnson, and unfortunately, we don't have a Lucia from Zeiss, which have the polyvinyl fluoride. So sensor from Johnson & Johnson I don't have any financial inclusion here. The polyvinyl fluoride haptics is what we need. What's the needle? 30 gauge inch thin wall needle for Lucia and 27 gauge needle for the sensor and the PMMA, if someone need to use the PMMA. Now, what else we need? We need 23 gauge micro forceps, tying micro forceps. One of the clue here in the Yemeni technique: 1 cc syringe, ink pen, and caliper, access ring, and cautery, a gentle cautery that we can use it, and most of them it's portable use, one used only, and that's the one that can give us the gentle cautery. Now, what else we need? We need the either trocar for the maintaining the intraocular pressure, or AC maintainer. Well, I'm not fun with the AC maintainer because it interferes with the technique. So I'm using the trocar because those cases we need to search for a lot of, because usually most of them, they have a posterior remnant of the lens, but they have a drop lens, or they have lens matter in the sulcus, or we need to clean the sulcus from the remnant of the posterior capsule, because it will interfere with the centration and tilting of the lens. That's why I'm cleaning, and I show on all live surgery how I'm cleaning the capsule, removing it in a way that we can fix the lens in its position. I'm advising all the beginner to use the Simul Eye, and it's there and on a website, and I don't have any financial enclosure here, from a Golden Ophthalmic. They can order it, and it's a very, very helpful in training on the Yemeni and flange technique. They can order it. It's a two eye in one box. Now, we will see a video here. The video shows the Yemeni technique on the Simul Eye, and you can start seeing that, first of all, the gross marking, and with the 2 millimeter from the limbal, the first mark, and then on its side there is a 2 millimeter also on side. On the other hand, on the other side, there is a 2 millimeter, but the other 2 millimeter is opposite to the right side. Those markers should be very clear, very clean, because it should be visible, and the important key of it is to create the tunnel. Here I'm doing the double needle technique. The first needle that it will kept inside the eye, it should be bent on 9 millimeter. The second needle that will be for the first externalization, that is for the leading haptic externalization, we can make it 11. And why the first one we made it 9, because it will be kept inside. And why it's kept inside, we can externalize. Someone will say, you can externalize. No, it's for the centration of the lens, because the needle will give a better length for the lens for the mobility. And you can see now I'm testing both haptics. It should be test in the needle that I will use here. I'm using sensor with the gauge 27. So that the needle, both needle, the microforceps is a key factor here. the tip of the haptics should be go perpendicularly and then inside, and those issues are important and should be tested before the surgery, not inside the eye. See, I test both goes easily and in. Now, the injecting the lens, the haptics should be clearly visible in a way that it will not be broken. Here, I'm doing paracentesis 6 o'clock, and this is the modification of it, testing the micro tying that it should go easily through, and then preparing myself to hold the leading haptics while I'm injecting the lens to externalize it in. And then we have now supported lens. The leading haptics is outside supported, and the trailer haptics also supported. Here I'm just centering the lens, and you can imagine that if we don't have iris to support, then we can do the technique easily. And then now I'm preparing the 2 paracentesis to go in, and the tunnel, which is very important. I'm creating the tunnel, putting the tip, and then holding the trailer haptics by internalizing the trailer haptic first, and then holding it with the micro tying gauge 23 from the other paracentesis in a way that my sight will be clear. And then perpendicularly, the tip should be perpendicular to, and then pass it, introducing it to, and then keep the needle in. Here, I will have enough length for the mobility. See, the tunnel should be created into its parallel to the limbus and then in. Now I will internalize the leading haptics, which is much easier than starting with the leading haptics. It's end with the leading haptics. Here, again, the tip of the haptic should be perpendicular to the bevel, and then here I will externalize the needle out, the assistant preparing the cautery, and my tying, it should be ready in a way that I can hold. Now a small flange, that will be more than enough. Leave it, and then I will go back to my trailer haptics, externalizing it, flange, and then reinsert that in, and the whole surgery and the lens center, and everything's fine. Now, if we will go to the real surgery, I will try to make it here. It's a phakic eye, a dropped lens in, and lens matter in. So all these we will skip it and see. You can see that this is the first needle with the 9 millimeter, and the second needle will be with the 11 full shaft, and then I'm just preparing the site. I will escape these. See, the paracentesis should be very in the direction of the paracentesis should be directed toward the site where we will create the fixing of the trailer haptics in a way that the manipulation and the introducing the haptics into it will be easily. This is the paracentesis at 6 o'clock to have the leading haptics out, and then testing the micro tying to go in, because sometimes it's difficult to go in. So I'm testing it, then creating the tunnel. I left the lens in, sorry, I left the needle in, and then injecting the lens, loading the lens, injecting, and preparing myself to have the leading haptics out. Now the leading haptics supported and out. Some difficulties for sure. The lens is upside down. I recorrected again. These difficulties, for sure, we will face it intraoperatively. Now I have two haptics out, and then I will start to externalize and introduce the trailer haptics first, where the needle is in the tunnel, and you can see that the needle start to be ready and go in here. Then I will go from the paracentesis to have the tip of the haptics perpendicular to the bevel, and then introducing it in a way that there will be some difficulties. I will left the needle in. That's why the length of it is 9 millimeter. Holding the trocar, that's why I like the trocar, in a way that it gives me the opportunity to have the tunnel in a parallel to the limbus. Now I'm internalizing the leading haptics in, and then holding it from the tip around 2 to 3 millimeter from the tip and perpendicular to the bevel, and then out. Now I will externalize the leading haptics, holding the haptics, and then cauterizing, creating the flange on the tip. This flange, I will leave it. I will go back to the trailer haptics, and my micro tying is ready to hold the haptics, and then another flange, and then recentering the lens by buried the tips into the tunnel. Now we will go, that's post-op. What's for flange fixation, just for taking time? So Calabrava in 18, he published one paper showing that the novel for flange transscleral IOL fixation, and that technique, I will show it to you using a 4 eyelets lens. And for me personally, I prefer the 4 flange because it's less complication and more centration of the lens. Now, if we will go to the surgery directly, we will see that here still I'm using the trocar because I need a lot of I need double tunneling. That's why I'm using the trocar. So here I'm using 2 tunnel instead of 1 tunnel. So on each side I have 2 tunnel, measuring it that it should be 2 millimeter from the limbus. And I will start cleaning, introducing the lens in. Definitely, I did the cleaning here. The video is accelerated. The lens that used is 4 eyelets. It's from Physio. I don't have any financial enclosure here. And the 4 eyelets, I will start from the first tunnel, go through the first eyelet. I prepare my suture. The suture is 5 or 60 polypropylene nylon. And then the suture will be go through. Here the suture will go through into the bevel, and it's much easier than the haptics. And there is no any risk of cracking or tilting or any because those are the main cause for the decentration. Now I'm creating a flange just to make it sure, or I will secure myself from slipping of the first suture. Then I will go to the another tunnel here, which is on opposite, and it should not cross the midline in between them. Going through the second eyelet from one side and introducing the other end of the suture, which will be I'm using it around 10 millimeter or 15 millimeter, and then taking it out, externalizing it, and it should be, see, the loop should be all inside. That's why I'm pulling from one side in a way easy to externalize it, holding it, creating the flange. So this is a primary flange. This is not the end flange. Now I will go to the other side, and other side have the same, holding what you can see, holding the trocar, using it for the first eyelet, and then externalizing it with a flange, and then the second tunnel, the second eyelet, and passing it into the bevel. Much easier than the haptics, in my opinion. This is in my hand. I'm doing it both according to the situation, and then externalizing it. Now, flange, and then the centration here. This step is an important step because centration of the lens. Now I'm returning back the haptics under the iris. I have 2 suture, I have 4 flange. Now I'm centering it. Then, now 1 flange will be buried into the tunnel. The 2 flange from these 2 sides, it's buried into the tunnel, and I have two suture that I need to tighten it according to the centration of the lens. And you can see here, I'm drying the site, seeking for a good cautery, because if the site is wet, the cautery will not work. So, and I need a very faint flange, then buried it into, again, cut and flange, and then buried into the site and the central lens. And I did here pupilloplasty, but it's not, for sake of time, it's not. Other use of the flange technique, just let us see this video, quick video, if Mohammed allow me. And
Dr. Safwan, can you make it fast, because still we have 2 talks.
Okay, I will try. Here we have iris dialysis, we have subluxation of the lens, and we have all of it. We did it with the flange technique. And if you can see that, first of all, I draw I retract the iris in a way that I can go through and do the cataract, and the cataract done. And then I implant I did the capsulotomy, and with the Ahmed valve segment, the capsular tension segment, I pass it here. It's not very clear, unfortunately. Then I remove the iris retractor and tract only the Ahmed segment by only 1 retractors. Then phaco done.
2 minutes, please, Dr. Safwan.
Okay, I will finish, and if you don't mind that, I can stop it, but just let us take this opportunity. Then the capsular tension ring also, it's done, it's in. Now I can reach to the end how we did it. Then flange into, then tunnel, and then the suture passed into the needle through the hole of the segment, and then out. The flange, the first flange will hold the Ahmed segment, and then it's centered. And then I did the dialysis of the iris also by flanging, by creating a loop outside, and then for 1 millimeter distance from the limbus. Here, the capsule being supported by flange technique, and the iris also supported by the flange technique. In this step, I'm doing the pupilloplasty, and the story all is finished. Thank you very much.
Thank you, Dr. Safwan. It's very nice illustrative of the Yemeni and the 4 flange, and the modified technique by Brian Kim. For sure, he's a very talented one. I'm going to meet him in an hour, so he's a very talented person I know here. So can you stop sharing, please, Dr. Safwan?
Yes, my dear.
I just want to thank Priya, because Priya should leave now because she's obliged in certain situations in her hospital. So thank you, Priya, for being with us and for your nice video and your new technique that you are going to publish soon, the reversed 4 flange. It's really amazing.
Thank you so much.
Yes, Dr. Safwan, I'm just going to highlight because it's a long presentation, but one before Meltus to start, and we should to say hi to Meltus. Happy that you are here in person, not recorded, as Dr. Mohammed said. Some issues of the Wi-Fi. I know you're in your connections. Dr. Safwan, just one question about the Yemeni. Before cauterizing the haptics, we should make it dry, because
that's what I mentioned that.
Yes.
Yeah, I mentioned that we need to dry the site, because otherwise the cautery will not, and then we will increase the power, and then we will have a very ugly flange. So we need to dry the site, and then make a small flange in a way that it will stuck in the tunnel and it will not dislodged. By the way, the stocking in the tunnel is very powerful in a way that sometimes I'm having a lot of complications removing the lenses, not from my side. I'm removing the lenses that's been implanted in Yemeni, and it's just like a fan inside because they didn't create a tunnel, and 100% if we are not creating a tunnel, it will be the whole lens will move upside down in all directions.
Thank you, Dr. Safwan. Thank you so much for this illustrated videos. Anyone can do the surgeries after you. You do step by step, and definitely everyone is going to follow what you are doing. So
thank you very much, Safwan. If there is any question, Ashraf, from any from the colleagues there, Tariq, is there anyone?
Actually, I would like to comment. It was a wonderful surgery, and I don't know if you can hear me. Thank you very much, and thank you for your patience. In Europe, still Wi-Fi is not as great as probably in the areas of United Emirates and all that. But anyway, it happens. I think that we have tried the Yemeni technique. We have tried over the last 10 years also the Canabrava technique and all that. I think that what makes really difference in sclerofixating IOL is the Carlevale lens, and the Carlevale lens has been made for that, and this is really the great advantage. And also the more advanced hydrophobic version of it is even better. And I for the last 4 or 5 years, I have stopped all the other techniques, and my experience over 100 Carlevale lenses shows that it is an extremely good lens with a steep learning curve, I can say, in the beginning, maybe your first 10 cases. But then after that, you will standardize the technique and you will have a reproducible result. I'm really fan, and I have stopped all these wonderful but technically difficult lenses and techniques to use. And I really urge you, I really want to propose you to start using it, and even you can get rid of any AC lenses if you have a stock of AC lenses in your theater, and just have a stock of Carlevale lenses. I think they are great, and it will change your way of doing all that.
Yes, I totally agree, and I think the company, there are 2 companies now, and they're trying to emerge in our region, in the Gulf areas and the North.
Don't have it in our region.
Yes, they are trying to make it safer nowadays, and I think it's going to change the secondary implantation of the IOLs. And really, it's a good lens also for posterior segment surgeon. They love this lens because of there is no tilting and stability even in vitrectomized eyes. Thank you, Miltos, for highlighting this issue. And we should move to your talk. I know that you are an expert in this field. So how to manage unhappy patients after multifocal. The multifocal can make the patient unhappy. So how to manage the unhappy of the multifocal? This is a complicated talk, I know. So let's hear it from you, Miltos.
Do have the video from our side?
Okay.
Hello and good afternoon from Thessaloniki, Greece. This Miltos Baliris. I'm going to present the management of an unhappy patient after multifocal IOL implantation. This management has a lot of different aspects that we're going to try to explain in this presentation, but most of the cases we're going to address the importance of taking care of the ocular comorbidity, and also of knowing the technology which is behind our IOLs, and how can this be an advantage or a disadvantage. One of the things that will be very helpful in the future are these amberometries, which can make clear how the lens is functioning inside the eye. So it's an in vivo function of the aberrations that we have when we have a patient with a multifocal IOL. Here you can see how is this multifocal IOL designed. You can actually understand the distance between different rings, and from that you can maybe realize the type of the IOL, whether it is trifocal or bifocal, and even the manufacturer. Also, here you can see that the central part has a power of 2.20, and in contrast, the central power of another high IOL has 1.75. So this is one interesting difference that we can pinpoint almost at 1 minute when you're looking at these diagrams. We can also see the source of the problem, whether it's coma or spherical aberration or astigmatism. Like in this case, the astigmatism is a bit high. And also we can have a kind of indication of how this patient's visual function is with this simulated chart. Now, finding the cause of the patient dissatisfaction and knowing how to fix it can turn a difficult situation into a happy patient. And this is very important, so that's what I will try to illustrate with all these pictures and theories behind it. Why a patient is not happy with a multifocal IOL? In most of the cases, in the vast majority of the cases, we have promised more things that we can deliver. So the standard thing that you can hear again and again: promise less, deliver more. In other words, under promise, over deliver. The other thing is pre-op assessment. Look for ocular comorbidities. Some of them you can identify preoperatively, and that can save you a lot of time, anxiety, and effort that you will put postoperatively to make a patient happy. When they come and they have problems with the visual acuity, look at the 4 C's, which are cylinder, cornea, capsule, cystoid macular edema, and centration. These are situations that in most of the cases you can correct. And for the cylinder, whatever is over 0.75 diopter can be disturbing in a patient with a multifocal IOL. So if you have astigmatism, coincide astigmatism before the operation, then you can use LRIs or opposite clear cornea incisions to treat up to 1 diopter, 1.25. And whatever is over 1.25, then you can use either a toric IOL or use PRK to correct it postoperatively. Cornea. In most of the cases, the patients come to our clinic with dry eye. In some cases, it's not just dry eye, but it's epithelial erosions, a kind of epithelial keratitis, and sometimes there's coexistence of meibomian gland dysfunction or other sources of blepharitis. So treat all these vigorously. Don't wait until they finish the other drops, but start it with cyclosporine or intensive lubricating. Now, it's a completely different thing if they come with an endothelial damage. You will wait for a considerable time for the endothelial damage to improve, but really subtle edema can reduce contraceptivity in an optical system which has already a reduced contraceptivity. So I think that if the patient continuously has corneal edema and you have recorded that in 2 or 3 consecutive visits in 2 to 3 months' time, then it's a time for IOL exchange. These are a few indications which I'm a bit more aggressive to treat with the IOL exchange. Photic phenomenon. The vast majority of patients' unhappiness is because of the photic phenomena. Some of them disabling, like in this second picture, that yes, you do have some halos, but most of the time this can be not so disturbing. The patient can do all the visual function without problem. But if it comes to that sort of intensity, then this is almost impossible for the patient to withstand, and that is the non-disabling problem. These unwanted optical images like halo here or glare are sources of IOL technology, are results of the IOL technology. This is a defocused image, and this plays an important role in the ocular aberrations that we have, this photic phenomenon. When do we have defocus images? When we do monovision, so one eye is for distance and one for near, and when we are focusing or we're looking at a distance object, the near eye will give you a defocused image. Or when we have multifocal IOLs, where we have simultaneous simultaneous vision, and also we have a simultaneous image in the retina, on the retina, one for distance and the other for intermediate and for near. And of course, we may have it in HOAs, in high order aberrations. The types are two: the negative, which comes in a kind of shadow in the periphery of the visual field, and the positive. We have the starburst, glare, halos. Negative dysphotopsia only can happen in patients with pseudophakia using an IOL which is a squared design. If we look at this schematic picture, you can see that when light comes in a 0 degrees from the visual axis, everything is focused on the fovea. But when it comes in 90 degrees, then there is a block, a shadow at the sharp edge of the IOL, and this shadow is creating this peripheral dark part that some people perceive. Now you can understand that if the distance between the pupil and the lens is bigger, then the shadow is more evident. So it's related mostly in the space between pupil and IOL. As for the positive dysphotopsia, some of these dysphotopsias can happen in other causes, either refractive error or can increase even with age. But in most of the cases, it's medically induced by the IOL design. Now, from the high ocular aberrations, you can see that almost all lenses do have some ocular aberrations, but they are not at all the same disturbance in these cases. Some of them are disabling, and usually I'm talking about halos and night driving, and some others are minimally disturbed. So halos and night driving had been shown by the patients that they are the most disturbing effects of the IOL. Simultaneous vision. When we have two images in the same time. Look at the schematic presentation, you can see we're looking for distance, and we have this part of the lens which is for near, the other which is for distance, the sharp image and the defocused image. If we're looking for something for near, then the sharp image is in the center and the defocused is in the peripheral. So we have two images in the same time or three images in the same time, then we have halos. And when this is more evident, when there is a high contrast situation, like at night, When you have dark background and light, then these second image or third image start appearing more. When you have low contrast, like in daylight, when you have light as a background and the light in front, then this usually the defocused image is suppressed. Trifocals, by definition, have two foci, so they can give you two different halos, but the most important is the second one. Now, two very important factors: size and intensity of the halo. The size is really dominated by the additional power, the IOL power, and the pupil diameter. So the higher the additional power, the larger the pupil size, or the lower the IOL power, then the bigger the halo size. Halo intensity. Here things are simpler. Bifocals and spherical IOLs can give you higher halo intensity. Apodized, when you look at the far object, can give you lower halo intensity. When they look at the near object, then they give you higher halo intensity. So, spherical aberration, bifocals, and apodization are the three factors to consider for the intensity of the halo. Now, why bifocals can give you a worse halo intensity? Let's go back one step and consider how the bifocals are using light intensity. Usually, they split light intensity into a far and distance image. So when they are looking at the far image, we have these two images simultaneously focused on the fovea, and you can see the second image has quite high intensity, so the halo intensity is high. When you're looking at the trifocal lens, the two or three other foci, other from the distant one, have much lower light energy. So because they have lower light energy, the images that they are superimposed for a far distant object have lower intensity. That's why trifocals had less visual disturbance halos than the bifocal. And these are some images. More light energy than near focus, the more concentrated vision at near, but the more halo intensity at far. This is one thing to keep in mind. The other problem for light dispersion, usually for the multifocal IOL patient, is due to PCO. So posterior capsular opacification can cause this kind of dispersion and can be treated with YAG laser. IOL saturation, one thing to remember when you have your Cyclone or your Pentacam, always look at the cap angle, especially when you have high hypermetra patient. Look at the angle kappa and look at the number of angle kappa. If it's more than 0.4, then this is a contraindication for multifocal IOL, because you will induce aberrations, because the IOL is going to be descended from the visual axis, and that can cause multiple high order aberrations, especially like coma and other ones. Look at the IOL technology relatively to the limbus, and then if there is a descended pupil, or in some cases we've seen that the pupil, when it gets smaller, it is slightly descended, we can fix that with argon laser iridoplasty or a surgical papilloplasty to bring the pupil in the center of the IOL. Now, because we know the IOL technology, we know that in most of the trifocals, the central part is the near vision part. So if the near vision part is not as strong, what we can do is, by using the pupil, we can direct more light into the area that we want to make stronger. So if someone has to have a stronger adding power and it's not sufficient enough for the patient to read, then we can use a pupil constrictive drop like brimonidine or pylo when they're reading in order to constrict the pupil and direct more light into the central part of the lens. If the problem is in the distant part and it's not related to a refractive error, then maybe diluted mydriatic, especially in some old patients' pupil where they're in a smaller pupil than normal, then a bit of a diluted mydriatic will help the distance, the light to go more for the distance vision and improve the distance vision of these patients. And always look at the retina. In cataract surgery, during cataract surgery, we may have over 70% of macular thickening, and 12% can be significant. So always use an OCT to check how is the retina postoperatively and treat. And in some cases, like I do most often, I use a prophylactic non-steroidal anti-inflammatory in order to prevent any cystoid macular edema postoperatively. In cases with epiretinal membrane or lamellar hole, then the approach should be surgical and in a different way. Posterior capsule opacification, we have discussed in the past that usually causes contrast sensitivity and glare, and make sure that when you decide to do a YAG capsulotomy, the source of the problem is there and it's not a refractive problem or glare on halo, which is going to sometimes be even worse after the YAG capsulotomy. So if it's a problem of low visual acuity, low contrast sensitivity or glare, then proceed for a YAG. Now to summarize the pearls for the multifocal IOL patient. Preoperatively, be careful with the low myopes, with the high addition IOLs, bifocals and sphericals. Always treat the ocular comorbidity, if possible, before doing the operation. And for IOL exchange, should be your last option. And this is my quick algorithm. What is the refractive status? If there's no problem with refraction, then it's a little bit of a joker. So look at the IOL, the pupil, the positioning between the two, identify what is sort of the photic phenomenon where the patient is visual acuity is disturbed. And if there's a problem with the pupil, then do argon or surgical iridoplasty. Very rarely you need to exchange or reposition. Look at the IOL properties. If it's a near vision problem, myotics. If it's a distance vision problem, mydriatics. If it's a problem at the IOL technology, then consider IOL exchange. And if there's a glare, then also some other low contrast or low visual acuity, consider doing YAG capsulotomy. If there's a residual refractive correction, correct it quickly, fix it quickly. Specs or refractive surgery will do the trick. And just one word for IOL exchange. Proceed with deliberation. This cannot be your first option, can be only your last. Try to identify if this is a source of a problem, so use a trial of RGB lenses, gas permeable lenses, and if the vision improves with that, then you can understand that the problem is the IOL. Do it quickly. Know how to do a good anterior vitrectomy, and handle the haptics with care, because you will need the capsule for the implantation of the other lens. And with that, I would like to thank you and conclude our presentation.
Thank you, dear Meltos. It's a very big presentation also. It's not an easy issue. It's a very big problem. But
as I say, Azrep, it's a very big problem because in most of the cases, it's a problem created by us. It's a medical problem. So we have patients with high demands. We give them these lenses. And if they are not absolutely sure what we have offered to them, then the problem starts. So it's a medical, let's say, disease caused by us, iatrogenic.
So we can summarize it in 3 steps. Steps before the operation, that everything should be okay for the patient, from the cornea, ocular surface till the retina. Steps intraoperative, choosing the type of the IOL, which is the most perfect for this eye of the patient. Not all IOLs goes for all the patients. And surgical steps should be in a proper way. Post-operative, as you said, you should deal with the problems when we put the IOL according to the situation. Either we manage with the IOL inside the eye, or we do the last option, as you said, exchange the IOL, or change the type of the IOL, because sometimes you use one eye, change one eye and leave the other eye according to the situation.
I'm on a happy and maybe difficult situations that most of the companies are sending the lenses, so that I do small studies to understand how the lenses are working, so that I can explain to the patient. And beware, never look at any sort of advertising stuff from the companies. It is never going to stay the line. Never look at companies made papers. I think whenever they approach you, just ask them to either give you a name of someone who is using it more often, and they can give you some details. They always come. I remember when the EDOF came out, and they said, well, the EDOF didn't have glare and halos. Well, the EDOF do have halos, especially the early EDOF lenses of the AMO lenses, we have a devastating halo. So always consider to try to discuss, because there are some lenses who can give you a lot of benefits. And listen to your patients. Listen to your patients' needs. Explain to them that they may have a benefit one thing and then lose something else. If they do that, then simple tricks like pilocarping or mediatics can do your stuff.
Do you have questions from the audience?
Dr. Ashraf, we are running behind the time. If you allow me, we can take the last presentation. And if you have a time, we can discuss any points, please.
We can present Dr. Safa Gihad from Morocco. I think her topic should be the first one, because she's going to talk about ocular surface disease before any cataract surgery, whatever the cataract surgery is. So this is the best ending for the first talk. So please, Safa, can you represent this talk, which is a very important issue nowadays in all our premium
trying to share my screen. Give me just a while. Cannot reach you. Wait.
Open the presentation first. Open the PowerPoint. Yes, and then choose share. You are going to find it.
Yes, wait, share. No, I didn't find it. I'm on Zoom, but I didn't find it. Sorry.
Okay, Safa, can you just close everything, then open your presentation only, and make it open. Then go to the click on the Zoom on the arrow to share the screen.
The desktop.
You don't need to go. Okay.
I cannot read. I cannot share my screen. I don't have the access to.
No, just go back.
You open
only your
Zoom
presentation.
It is already open.
On the Zoom screen, and you will find it down on the middle.
Now it will be then an arrow, green arrow.
Yes, in the middle down.
Yes,
So
but it gives me basic fichier or wait. No, I don't have access to the presentation. Wait. There is a problem. Help.
Okay.
You are not sharing your screen.
Okay, can you do one thing? Can you give us your, you have open Soria, if you can please access her laptop, please?
Yes.
Yes, sir. Ma'am, do you have any desk with you?
You have any desk with you? Any desk?
No, doctor. Open your presentation please.
It is
Minimize.
open.
Open
And
it.
then you might
is
be able to
minimized.
see the share screen button, center
Open
of the
Zoom.
screen.
At the bottom of your screen.
Click there on the basic. You might be able to see the
Now,
PowerPoint presentation.
when I click on Zoom, when I try to share my screen, it gives me a screen with the basic, advanced.
Yes, ma'am. Yes, ma'am.
Yes.
Basic.
Yes,
You have to go on the basic.
Basic. Okay.
Yes, ma'am. And then, ma'am, you can share your screen from there.
Okay. Share. They ask me if I want to open the preference system. I allow.
Yes, ma'am. You can.
Yes, and I utiliser le mot de passe.
So maybe
we have
You can discuss.
Okay.
Can I ask a question to Dr. Validas? Thank you for your presentation.
Can you discuss?
The traditional questions that we always face, will you use a multifocal lenses or trifocal lenses in post-laser vision correction, because these are the most demanding patients that are keen to be free of glasses after cataract surgeries. So what are your recommendations for those patients?
Well, for patients that they have undergo, well, first of all, let's take two different kind of approaches. If they had LASIK or PRK, in some cases, we can use it, and I will explain to you what kind of lenses. If they have RKs, I never put on RKs any sort of multifocal. Now, if the initial treatment was a low mild, like 1 or 2 diopters or 2.5 diopters, and the topography that you have is a quite normal topography, and you don't have many differences that you can understand that is a big problem, or if a patient had an astigmatic correction, again, a low astigmatic, I have no problem of using a trifocal lens, although I'm looking at the asphericity, and sometimes I put an EDOF lens. Now, if they have hyperopia of 1 or 2 or 3 diopters, then I prefer to use an EDOF lens, because that will augment the positive asphericity that some EDOF lenses like the Technis iHance have. So in a way, if you use a Technis iHance in a hyperopic patient that has a hyperopic LASIK, then it will be augmented your result. But I will never use an aspheric lens on hyperopic in a post-hyperopic LASIK treatment. I will use either a standard spherical lens, or I will use an iHance lens for these cases. Now, whatever is more than that, then I will go for an EDOF or a standard lens. But I always explain to the patient that when I have, for instance, a patient that has -6 or -7 diopter previous LASIK treatment, then obviously by the way, negative or positive asphericity, spherical aberration, can give you a depth of focus. It doesn't have to be only positive. Even the negative can give you a depth of focus in a different way. So both of them will have a kind of a depth of focus because of their laser pigment, and I will use a kind of EDOF lens for them. But I will avoid trifocal lenses if they have a very high previous LASIK correction, high in diopters.
Okay, EDOF monofocal lenses, because then we have EDOF trifocal and EDOF monofocal.
No, because
using EDOF monofocal lenses.
Sorry, what? I didn't hear you.
You are using EDOF monofocal lenses.
But they do the extended monofocals.
Depth of focus.
Or now I'm using pure EDOF, like the Elon lens, the Elon lens from Medicontour, another one from Germany, which is the
IC8.
No, the
IC8.
No, it used to be Comfort. Now they have a different name. I don't remember now. But I'm doing a study on Elon lenses, which are similar to the Alcon Vivity. Similar.
Yeah.
Both of them, Alcon Vivity and Elon, had very good performance up to about 40 millimeters. But they also, both of them, reduce a little bit the contrast sensitivity, not much. The other thing is, of course, the price, which is almost half in between comparison. But anyway.
So just one comment.
Yeah.
Just one comment that's important, because when you are saying that the patient after hyperopic, yes, I do agree that I'm seeing the spherical abrasion, whether it's negative or positive, and when it's negative, I'm using even the modified EDOF, means that refractive EDOF, not diffractive EDOF. Definitely, K-reading post-op, hyperopic treatment is an important issues with the high order abrasions also. Some lasers can create some high order abrasions in coma site, not only in the spherical. I think that the presentation start to be ready for Safa.
Okay, I think Safa is now ready. If we can allow her to give a very fast talk. We are sorry for the
Unmute.
Can you mute yourself?
Unmute.
Unmute, Safa.
Safa, unmute.
Okay, can you, the IT, unmute Dr. Safa from your side, please?
Okay,
unmute yourself.
Unmute yourself, Dr. Safa. We are not hearing you. We are not hearing you, Dr. Safa.
Is it okay now?
Yes,
Yeah,
yes,
no,
excellent. Thank you.
Well, I'm really sorry for this problem, and I promise you that it will be a light dessert after all what we heard today in this session. Well, let's go. I'm gonna try to answer to this question. Is dry eye a problem in cataract surgery? I wanna thank everybody, the team of MEOM and all the Yemeni societies, of course, for inviting me. And the answer is obviously yes, it's a problem, because managing an ocular surface disease is the key of cataract surgery. Because if after having done what you have brilliantly presented today in your session, we still have an unhappy patient, it is definitely a problem. And the answer is reside first in our Hippocratic oaths that compels us first to do no harm. And when we are worsening a pre-existing fragility, it is in fact a harm. Well, you will certainly recognize Mrs. S that came to our office of all of us 3 months after the surgery. She did what she calls just a cataract. It was a phaco with a monofocal implant. The surgery was okay, good postoperative refraction, good incision, good rhexis, while the patient reports foreign body sensation, tearing, fluctuation, blurred vision, especially at night and while reading. And she specifies that she has no complaints before surgery, apart from the decrease of vision, of course. Well, before doing a macular OCT or a capsulotomy, let's have a step back and let's see if we didn't miss something on the ocular surface. Indeed, this patient has many abnormalities in the ocular surface. She has an unstable breakup time with a tear film, a bad tear film, some crusts and foam on the lid margin, meibomitis, a Meibo scale grade 2. And we did an ocular surface analyzer that confirmed this evaporative dryness with lipid deficiency, with some bad no invasive breakup time. And I confirmed by corneal topography that shows many irregularities on the anterior surface. The epithelial mapping shows two focal thinning and many irregularities in the anterior surface. Well, I treated her, but I still see her permanently every 2 or 3 months with the same complaints. Doctor, they have cut a nerve under my eyelid and I see it and I feel it just right here. Here is my first golden rule. It is much easier to treat a patient which was informed that to explain him afterward that it wasn't your surgery that was responsible for the bad postoperative course, and premium IOL patients are less forgiven. Do you believe that the initial contract with Mrs. S was fulfilled? Maybe not, because we should understand first what does quality of vision and supervision mean. It's not seeing more than 20/20, but it's being able to see good in all life conditions. And this is definitely related to the tear film, which is one of the main actors. What Mrs. S have is what Tifus used to describe as iatrogenic dry eye caused by the disruption of the ocular surface homeostasis. And this is what makes the third of our 20/20 patients unhappy after a monofocal IOL, and more than it is the second cause of insatisfaction after premium IOL. Dry eye patient and cataract patient have many similarities. They both are very common pathologies. They both are age-related, and 80% of our candidates of cataract surgery have dry eye. They have also many comorbidities and take some drugs that can make the surface worse. This is here my second golden rule, which is to have a good history taken and ask about risk factor that can make things worse. We are facing a population with frail ocular surface because 75% are underdiagnosed and have asymptomatic dry eye, and the mammalian gland dysfunction exists in more than half of our refractive surgery patients. Dry eye in cataract patient has been brilliantly described in FACO study published by William Trachel that shows that 77% of our patients have corneal staining and more than 60% have a bad tear breakup time. Well, how dry eye affects cataract surgery? To understand, we should first understand the role of the tear film. The tear film is the most important and the first refractive surface of the eye. A dry eye have an irregular tear film with a thickness less than 20 micron, with a variation of refraction reaching 1.3 diopter and high order aberration that can be more 25% than a normal eye. Now, this is a wonderful study that shows the variation and the changes of the wavefront aberration between two blinks. And the conclusion is that the lowest degree of high order aberration is seen between the 6th and the 8th seconds. And that makes us conclude this the third golden rule, which is the best time to take any capture with any device using the anterior surface parameters is between 6 and 7 seconds after the blink. Fortunately, dry eye treatment improves quality of vision, as we see here the improvement of high order aberration and the point spread function after a drop of lubricants. Now, what about the preoperative testing? We know that dry eye changes the K reading, it gives inaccurate biometry, and this is more noticeable with premium IOL. This is what is already known. But what we learned recently is that astigmatism changed up to 35% in dry eye patient, and pain can last and remain after the 6 months in 35% after surgery in dry eye patient, and the dry eye is responsible for a postoperative visual fluctuation and an increase of high order aberrations. This is a wonderful paper published by A. Petropoulos and his team in the Journal of Cataract and Refractive Surgery that shows the link between the hyperosmolarity and the error in the refractive in the biometry. It shows that people with higher osmolarity in pre-op have more risk to develop post-refractive surprises up to 5.5 diopter. Now let's see how cataract surgery affects dry eye. Cataract surgery leads to a decrease in breakup time, decrease in Schirmer test, and it can lead to the occurrence or the worsening of the ocular surface dryness symptom in both groups, those who are already known as dry eye group and those who are not. Now, what about the lid margin? Cataract surgery leads to abnormalities of the lid margin. It alters the secretion and the quality of the MEOM, and it leads to a worsening of MEOM score, and this is significantly worse if the patient is already having a dry eye. The heterogeneity depends on the stage of the surgery. The speculum leads to the lid dysfunction by compression and obstruction of meibomian gland. The povidoniodine and the anesthetic leads to a tear film instability with less mucus production. The incision leads to a nerve suction. Yes, and an alteration of the corneal sensitivity, the blink reflex, and the lacrimal secretion, and microscope, the light of the microscope leads to phototoxicity. And last but not least, the drops with the preservative toxicity leads to a tear film instability. Now, once happened, how to manage? 3 keywords: prevent, prepare, and treat. We agree all that it needs an additional time to detect, to inform, and to treat if pre-existing dry eye, eyelid hygiene, preservative-free artificial tears, and maybe to initiate, if needed, the anti-inflammatory treatments, doxycycline, and nutritional substitute. During surgery, we need to remember that we should limit the operating time, use the topical anesthesia reasonably, just shortly before surgery, preservative-free with the viscous agents, ideally, adapt the brightness of the microscope, hydrate the cornea, but not too much, use HPMC ideally to minimize the incision site and to avoid limbal relaxing incision in dry patient. After surgery, 3 keywords: hear the patient, trust the patient, and treat the patient, because an unsatisfied patient with dry eye suffers. He is not an annoying patient. You should treat him aggressively with artificial tear, many drops a day, to slowly decrease till 4 times a day. And if pre-existing dry eye, we can maintain the treatment 2 months with 2 drops a day. Well, we still have an unmet aim, which is to try to identify healthy persons that are susceptible to develop dry eye symptom after cataract surgery. And that was the aim of Villani and his team with this paper. They tried to build an ocular Frailty index based on some simple data with non-invasive and low-cost procedure. They put a cutoff value of 0.3, above which the cataract asymptomatic candidates are highly risky to have post-surgical dry eye symptoms. Knowing the importance of this issue, the Asper's corneal team developed an algorithm to aid surgeon in efficiently diagnose and treat visual ocular surface disease before any form of refractive surgery. And the cataract and refractive surgery are one and the same, because which step of cataract surgery is not a refractive one? Now, my take-home messages are those. We are in an ever-evolving field, which is the cataract procedure. We reached the increasing of safety and efficiency, but challenges increase exponentially with ocular surface disease. Cataract surgery today is not a technique to improve visual acuity, but it's a path for a better quality of life. Ocular surface should be carefully evaluated, optimized to predict the exacerbation and to provide the explanation of post-op dry eye. And our patient will be more accepting if they were before, if it were explained before, and we are relying on the artificial intelligence that can help us to be more comfortable with those kind of patients. Thank you.
Thank you very much, Dr. Safa. It was very nice and excellent. It is one of the best talk. Thank you very much.
I tried to do it lazy because it was
okay.
Time is taken away.
Then you stop.
I do apologize from the next sessions, but I think this last talk we present, it can be part from their presentation, because oculoplasty, they will talk about usually about, so yes, 15 minutes, we didn't take any 15 minutes from them. So we are exceeding only by 15 minutes. Shukran, Dr. Mahmoud, Dr. Isam, thank you for giving us more time, because we start actually a little bit late. I'd like to thank all our speakers in our session, Dr. Ashraf, Dr. Safan, Dr. Miltos, Dr. Khalid, and Dr. Bria, and Dr. Safa for this excellent presentation as usual. And thanks for Yemen Ophthalmic Society for giving MEOM this opportunity to participate with them. And I will handle if there is any question or comment before we conclude our session. We know we are late. If there is any word from you, Dr. Ashraf, before we conclude, or any one of our colleagues.
I want to thank every one of the speakers. Every talk was eminent, and they give the best explanation for the topic that was suggested for the talks. Thanks for everyone. Thanks for the Yemeni ophthalmology conference. Thanks for Dr. Mohammed, who gathered us together, all together. And I want to say hi to Dr. Mahmoud and Dr. Assam. And
thank you, everyone. Thank you, Dr. Ashraf, Dr.
Thank
Mohammed.
you very much. From our side, we can say goodbye and see you, inshallah, in the future. Inshallah. Thank you. Assalamu alaikum. Bye-bye.
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 كيف بريك